Ask Me Anything. This is a production of MyAmericanDoctor.com, which is a group of highly qualified doctors that provide second opinions to anybody who wishes to get one. And we have a very special program today because we have on the program two highly qualified dermatologists, Doctors Vineet Mishra and Dr. Daniel Friedman. Now, they're both dermatologists. Welcome, Dr. Mishra and Dr. Friedman.
Thank you.
Thank you.
Before we start, I'd just like to remind the audience that we're going to be discussing a lot of very interesting things today, but none of this is meant to be specific advice to anybody. You are supposed to actually talk to your own doctors about it. And if you do want more information, you are welcome to log on to myAmericanDoctor.com and make a formal second opinion appointment and get all specific information pertaining to you on a one-on-one basis. Now, having said that, let's get started. So, Doctors Mishra and Friedman, when I was preparing a little bit for this talk, I came across this amazing statistic. It says that skincare alone globally takes up about $180 billion dollars, with more than 40% of that being allotted to the beauty segment itself. So obviously, skincare, and I'm using that in the broadest of terms, is something that almost everybody partakes of in some way, shape, or form. So I'm sure we'll have a lot of things to discuss. But as a starter, Dr. Mishra, would you give us an idea as to what it takes to become a dermatologist? What kind of training do you get after medical school?
Sure, absolutely. So basically in the US, you, as you said, do 4 years of college, 4 years of medical school, 1 year of internship, and then 3 years of residency, after which some folks can do a fellowship as well. Uh, Dr. Friedman did a fellowship in San Diego. I did mine in San Diego as well at two different institutions at the same time. And the process is fairly rigorous for dermatology. And there's many aspects to dermatology. So some people may focus on cosmetic dermatology, surgical dermatology, dermatopathology, and so forth.
So that's quite a lot of training. I think for the people like me, we probably underestimate the functions and properties of the skin. If you have to undergo such rigorous training for it, there's obviously a lot more to the skin than meets the eye, so to speak. So, would you mind just giving us an overview as to why is the skin important? What are the basic functions of the skin? What does it do?
Absolutely. The skin is the largest organ of the body. And in dermatology, you would cover skin, hair, and nails. And the skin helps to protect us from the outside external barrier. And at the end of the day, the skin functions in so many different capacities, from helping us to maintain our organs, of course, helping to provide us our cosmetic look. And the skin transforms over time. It's dynamic. And there's a lot of immunology that's involved with the skin that can lead to inflammatory conditions. And the skin itself is unique to each person, has its own kind of code. Dr. Friedman, do you want to add a few lines about the skin as well?
Yeah. And importantly, I think the skin keeps moisture in, keeps the water content of your body stable, fights against infection. As we know, someone who gets 30–40% of their body burned, it could easily be fatal, right? So the skin is there to kind of protect every other organ system from bacteria getting in easily. So it's very resistant against a lot of things in the environment. And it really is there's a lot of aspects of the skin, and that's why dermatology, is a 4-year residency program. There's a lot to learn about it.
Excellent. So, starting with a mile high view, what are the general things that people need to do to take care of their skin on a day-to-day basis?
Yeah, I think it's pretty simple on a day-to-day basis. Keep your skin clean. Uh, 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 that's number one. Number two is sunscreen, especially us with a more mild skin color, what we call Fitzpatrick skin types. I would be probably a type 2. Vineet might be more like a 4 plus, somewhere in that range. We Caucasian patients don't have as good of a natural sunblock. People with darker skin have a much better natural sun protection. So the lighter your skin is, the more strict you should be about sun protection. But I still feel anyone of any skin color can use sunscreen because the sun constantly is trying to degrade our skin, to age our skin, to promote things in our skin that we don't want to happen, like skin cancers. And one of the biggest misconceptions that we see, because we have a lot of darker skin patients in Austin, Texas as well, is that darker skin patients don't get skin cancers because they have the natural melanin that blocks UV, which is true to a large extent. But people with dark skin can absolutely still get skin cancers like melanoma and other rare skin cancers. They don't get the kind of skin cancers that someone that my skin color might be more prone to, like squamous cells and basal cell skin cancers, as much. It's much, much more rare in darker skin patients, but they're still at risk for sun-related damage.
And just to add a couple points to that, in the South Asian population, there's a high rate of eczema and dry skin.
Yeah.
And there's a few things you can do to protect your skin from getting dry and inflamed and irritated. So, for example, if you take a shower, use warm, lukewarm water, not hot water. It's great to moisturize. I prefer creams over lotions because creams have a higher content for moisturization to lock in that moisture barrier. In
Hmm.
terms of products, try to use unscented products because sometimes products with fragrances, dyes, and perfumes can also lead to irritation. And when you do moisturize, you want to moisturize ideally 3 minutes after getting out of the shower so you can lock in that moisture. There are small things that you can do, especially in the wintertime, to help to protect your skin, because eczema is very common, I've seen in the South Asian and Indian population.
And one of the
So,
biggest questions, sorry, Kailash.
no,
One
no,
of the
please.
biggest questions that I get from cosmetic patients is what can I do to protect my skin long term, right? Usually these patients have good skin, there's no ongoing issues. It's just how do I plan for the future? And the biggest things that I say, I call them the big four. I didn't make that up. It's well known in dermatology are sunscreens, number one. Number two would be a retinol. That is a product that helps with skin turnover. And as you ensure that skin is turning over properly, it just helps prevent against chronic sun damage. Number three would be an antioxidant product. Antioxidants help reverse sun-related damage. So you get these weird molecules that form in response to sun damage, and these help kind of get rid of them and move them out of the skin. And the last one is growth factors, because we know that growth factor products, which are very prevalent in the skincare market right now, help with collagen building and elastin building. And those are the things that degrade over time in our skin. So these are not things that are essential for anyone. And a good moisturizer does go a really long way for proper skincare. But these are things that people can do to help slow down the aging process and help minimize sun damage over time.
And just to add to that point, one of the things that I've noticed is a lot of South Asians, Indian population deal with issues of pigmentation. And this piggybacks off of Dr. Friedman's comment that sun protection, melasma, unfortunately, is very common and very difficult to treat. Uh, Dan and I had the honor of going to Singapore to discuss kind of skin and dermatology at a conference there, and we learned very quickly that in Asia, pigmentation is a very big concern for patients. And there's different products that can be used to help to clear the complexion, but just going back to the basics, sun protection is key. Now, in the Indian population, specifically, there's various conditions such as melasma, lichen, or LPP, and so forth. And but the foundation remains, you know, good face wash, good moisturizer, sunscreen, antioxidants, growth factors. That's your baseline, and then you can build from there if needed.
So these substances that you're talking about, are they all locally applied or are they systemic, or is it a combination of something you swallow, or is it all local application?
Yeah, these are a local application. These are the best way to get to the skin. Really, the only reliable way to get to the skin that we know of is applying it directly on the skin, as far as improving the quality of the skin and minimizing sun damage. We get a lot of questions, I know I do, about collagen supplements. And it just doesn't, number one, 99.9% of those supplements, there's no real rigorous clinical trials that have been done. So we don't know if they work or not, right? You can guess that, well, when you eat something and it's broken down into the base molecules and amino acids and proteins, whatever's in there, the body just shuffles it wherever it wants to send it. It's not that collagen's not going to your skin, it's going to the bloodstream, and the bloodstream does what it wants with it. So there isn't anything that we know of by mouth that will change the quality, collagen, elastin content of your skin. So these are things that you apply directly on the skin. Some get absorbed, like antioxidants and retinol to some extent. Growth factors and sunscreens are not. They literally will stay at the very top of the stratum corneum, which is the very top layer of skin. That's the dead layer that rests on the surface. So they're meant to be applied right on the areas.
We hear a lot about omega-3 supplements. Is that something that is also protective for the skin?
I mean, to the best of my knowledge, I don't think it has any, reliable benefits for the skin. I feel like there are benefits to omega-3s, for maybe cardiovascular health and lowering cholesterol, which is thankfully outside my field. But I don't necessarily see it as any negative for skin quality. I just am not aware of any good study showing that it helps the skin itself. So I never tell people to necessarily stop it. Uh, the one area where people can get into trouble with those is that they can definitely make people bleed. It can thin your blood, and to me, it's not as reliable as something like aspirin, where most people on it will get bleedy. It's unpredictable, and some people get much more bleeding than others on it. And so, if we're doing procedures on them, we will always have people stop those at least 10 days before, because I've seen some very impressive bleeding with patients on those alone.
And just to piggyback on the idea of what you can do for your skin, both topically and orally, there are certain oral things that are in studies, like niacinamide and so forth,
Yeah.
looking into whether it can help to promote better skin health. For melasma, tranexamic acid is also available in the oral tablet form, which in Asia is actually very commonly used. That can help to suppress the melanocyte production of melanin and therefore help with pigmentation disorders. In dermatology, there's a lot of research being done. Obviously, there's a lot of advances as we speak. For example, for hair, if someone's trying to focus on hair growth, you have your topical minoxidil, you have oral minoxidil, there's finasteride. But as Dr. Friedman said, there's pros and cons, there's risks and benefits to this. And we're also looking into different ways of drug delivery, of how we can get the molecules into the skin, so such as through microneedling or laser-assisted drug delivery as well. And this remains very hot topics because the research is evolving, and there's a lot of data that we see every year that comes out.
So, in terms of the general measures that I've heard both of you talk about today, it is keep your skin clean, keep it healthy. If you're going out in the sun, make sure you use a sunblock, regardless of whether you're light-skinned or dark-skinned.
Right.
And several of these topical lotions are beneficial, useful, particularly along with sunscreen if they're moisturizing, have vitamin C and other such antioxidants. Did I
Exactly.
kind of get it right?
Perfectly.
Yes,
All
and
right.
keep in
So
mind that everyone's skin is different. So, for example, if you have a patient who has rosacea, which is where they get slight redness or pinkness of the face, central face, their skin tends to be more sensitive. It tends to be more dry. And so I think it's important to understand the baseline. Some people may have very acne-prone skin, very oily skin. And so therefore, your face wash, for example, has to be appropriately used. So if you have very oily skin, you need something that's more of a deep clean versus if you have a more dry skin, more sensitive skin, maybe a gentle cleanser instead. So it's important to, I think, speak to a specialist so that you can understand exactly what your skin type is. I've seen some patients who, for example, may have rosacea, and that's the redness of the face, and they will use like tretinoin topically, which is a retinoid and a strong cleanser. That's only going to exacerbate it. And there's certain things that are linked to diet. Diets are a very hot topic. So, for example, people who are acne prone, who eat high sugars, will probably tend to have worsening of their acne as well. If you have a patient who has rosacea, then that can be worsened if they, for example, eat spicy foods, consume alcohol, enjoy coffee or chocolate. There's a whole host of things that can flare the skin. So diet is actually being kind of researched a lot more now because I think there's an integrated model for looking at the skin, not just as the skin by itself, but in conjunction with other parts of I guess the ecosystem really. And so I think there's a lot of things that people have to be aware of about their skin and modify their lifestyle, their diet, and so forth accordingly. And just to add one comment on the skin cancer side, there's certain types of cancers that are present that are more prone in patients of skin of color or darker skin tone. So, for example, for melanomas, there's a subtype called the acrolentigenous subtype, which is actually found less in fair skinned patients and more in darker skinned patients, more so in the hands and feet. And so there should be kind of an awareness of what growths are on the body. And if there's any signs such as pain, bleeding, and so forth at the site, or any changes to a mole, because there are certain tumors that can be found that are independent of skin tone or skin shade as well. So that's more on the oncology side of it. But the key thing is to know that one has to be in tune with their skin.
So it's obviously a lot more complicated subject than anyone would guess when you're first looking at it. Uh, if you think about what you normally see in your day-to-day lives, we'll first talk about that before we go into what you see most commonly in your clinics. But what do you see most commonly as you go about your day that people do that you think they should not be doing? Do you see something that is persistent very common that you say, gosh, I wish they wouldn't do that, or I wish they knew better? Is there any such thing?
I
Well, one
think
thing,
in
go
go
ahead,
ahead,
Vineet.
Dr. Surgeon. Okay. Yeah, so you know, I'm going to give a generic statement that applies not to dermatology, but to all medicine. If you have a problem, let's say with your finances, you go to your accountant. If you have a problem with something legal, you go to an attorney. If you have a problem that's medical, people tend to go to Instagram, TikTok, Facebook, their aunt, their uncle, their cousin, their nephew, their nieces. And then at point number 55, may come to the doctor saying that I've consulted the entire world. So having said that, the nonsense that's out there is ridiculous. And I think this is especially true in dermatology because now everyone who has a TikTok account, Instagram account, is a expert in nonsense. Dan, go ahead.
I think that's a great point. And building on one of those social media trends, something that a lot of patients bring up to me and people on the street bring up to me is my skin is dry. I need to keep drinking more and more water. That's what, I'm more nuanced issue than what Vineet brought up, obviously, but it's one of those things where it's interesting because it gives you kind of a very broad idea of how good the skin is. You don't need to drink 8 gallons of water a day to keep your skin from being dry. And if you have dry skin, it's not a reason. The reason is not that you haven't been drinking enough water. I always say drink enough water so that you're not thirsty, but dry skin, especially severe dry skin, needs to be treated by a doctor, or at least will require the recommendations of a dermatologist. It's not a factor of should I drink more or less water. That's just one of those common things that, for some reason, has become ingrained in the national psyche, at least here in the United States, where I just have to keep drinking more water and that'll protect my skin. The skin's very resilient. It can handle a lot of stress.
And just to add to
So,
that,
yeah.
oh, I'm sorry. One thing I will say is that, sometimes people look at dermatology and they think it's all aesthetics or it's all cosmetic. But when we take care of patients, for example, a teenager with acne, or a woman postpartum hair loss, or a patient who is, let's say, older and has eczema that's getting worse because as you get older, you lose more water content in the skin. It actually can be, there's a lot of psychological uh, kind of impact patients with psoriasis and so forth, or hidradenitis suppurativa, and where they get these boils underneath their in their axilla, in their armpits, their groin, and so forth. And so there's a element to skin that's much deeper. And I think people have to realize that. And I think people have to address that. We have, patients who have rosacea who are shy to go out because they sometimes perceive that the spotlight's on them. They're self-conscious of their rosacea, or people who have rhinophyma, which is the enlargement of the nose because of the sebaceous glands. So one thing I do want to make a comment on is that that dermatology is more than just skin deep. There's a big psychological impact, and with the advent of social media, especially on young women and teenagers and young adults, the psychological impact is even bigger. So one should not dismiss a claim that if someone says, "Hey, I'm concerned by this," like hair loss, you may find a patient who cosmetically has phenomenal hair, but has experienced more hair loss, and for them, that could be the most devastating thing ever. So everything has to be put into context. So I just want to make that comment about psychology and dermatology.
Yeah, we call that quality of life issues. So if you see clinical studies, they always look at quality of life and how a condition affects the patient's quality of life and how a treatment improves it, right? And I think part of it, even though this is more than a cosmetic issue, is skin is very visible, right? If you have cancer, a lot of times no one knows, right? Unless you tell them, they don't know what's going on in your body. You can't see it either. But when you have a major skin condition, it can be extremely noticeable, and that vastly decreases your quality of life.
So, from looking at it from the other side of the table, how do you know who to go to, because you can walk into any given store and you're going to have people sitting there that will tell you, hey, come sit down here and we'll analyze your skin and we'll recommend products for you. And so that starts, say, from I'm assuming there's some sort of cosmetologist, and then you go to get your hair done, and that person might recommend some products, and all the way the apex of that pyramid would come you guys and the dermatologist. The question is, from a user standpoint, how do you decide whether you need to go all the way to see a dermatologist? Do you just stop with your cosmetologist? Or, where do you go? Or do you just pick stuff off the counter?
I think being here in the US, what I tell people who ask me this on the street or friends of mine, my recommendation is always you cannot go wrong going to see a board certified dermatologist, someone who has that ensures they've had proper training in skin and skin care, can manage all forms of skin disease, and they should be able to give you the best advice as to what kind of treatment or preemptive therapy, if you're looking at more long-term skincare, you should need. But if it's more of just a mild cosmetic issue, a cosmetologist or someone in that line or an esthetician, as we have here in the United States, may be able to help you sufficiently. But I feel you're going to always get the best advice from a board certified dermatologist.
And let me add to that one comment. We see patients who have seen, like I said, everyone else. They've
Right.
been to the Macy's store, they've been to Sephora, they've been to Ulta or and all these places. They have dropped more money than you and I would think. And I have patients who come in with bags of products. I saw a patient, 19-year-old girl, college woman, came in for acne, and she said, "Oh, I tried a few things." And I said, "Oh, can I see what you brought?" Well, it was like 23 products. I mean, literally on the counter. And she had been going down this road trying to treat her acne and was very frustrated. So I would say that if you can, go to the top, go to a board certified dermatologist, someone who can give you expert advice. Because the problem is that you will probably spend your time and money going the wrong places, only to end up at the board certified dermatologist level.
Yeah, and adding to what Vineet said, the problem these days is not did I go to the wrong person? It's you don't even need to go to a person, right? You can go online and get skincare products. You don't need to talk to anyone. You just do like a little virtual chat with someone who may or may not be a doctor, and they send you all these products, which it might be you may luck out and may be the right thing for you, but you may also get into serious issues, right? Getting medications that you don't need, that are not going to help you, that are just going to delay the process until you get proper treatment. So again, I feel like going in to see a board certified dermatologist is fairly easy, kind of low risk, and they can at least guide you as to what the best treatment may be. And then from there, it's up to the patient.
Okay. Well, that I think is excellent advice. So let's now move into your office, let's say, and what would you say is one of the commonest things that people come to see you about? Is it acne, perhaps?
I see a lot of acne from young teenagers to people in their 40s or 50s, especially women in their 40s plus or minus are very prone to acne of their chin and jawline. We call that more hormonal acne, which is driven by estrogen, especially women that are not at menopause, but kind of getting closer and closer to that era of their lives for some reason are more prone to those. And depending on where you are in life and what kind of skin you have and all those other factors may determine what kind of treatment is ideal for you. There are treatments that we will use on those 40 or 50-year-old women who we would not use on teenagers. So there's a lot of different therapies out there. There's topical, there's oral, and now for the last 4 or 5 years or so, we've had a laser treatment for acne, which we never really had before. We had some light therapies, which came with tremendous amount of downtime. But now we have lasers, two different lasers in the market here in the United States that are specific for the oil in your sebaceous glands. So it turns them into little, microscopic grenades, and it ends up killing the excess oil production. And so it can make dramatic differences, permanent differences, at least to the best of our knowledge, in acne, which is really, really useful for a lot of patients. And
Dr.
and
Mishra.
Yeah,
and especially
and
because a lot of patients are hesitant to undergo kind of years and years of topical and oral therapy. And so I feel like a laser option is really valuable. We also have the gold standard, and it's always been and probably for now will remain the gold standard, which is isotretinoin, which is a medication that is essentially meant to completely shut off the excess oil production. So like I said, and I'm sure Vineet will build on this, there's many options for acne out there.
absolutely. The top things I see in clinic are acne, hair loss,
Hair loss.
um, eczema, warts, you can probably say is up there too.
Mhm.
Um, Skin cancer. In the South Asian population, um, once I went to it was like a dinner party with my mom, my dad, about 15 years ago, and I was surrounded by all the aunties. And it was like a 2-hour grilling session on uh, hair loss, nail problems, dry skin, pigments, pigmentary issue. And the truth is that I mean I kind of enjoyed it because I was being helpful. It was a long night, but I think that the message that we do want to bring across is that there are actually good treatment options, safe treatment options for most of these conditions, and you can actually get good results that are very sustainable as well. Acne is a good example. Just the fact that we have a laser now for acne is huge. Accutane, you can do red light therapy and so forth. There's so many different ways to approach a problem that it's no longer that it has to be something systemic or something just topical. You can do like a multi-modality approach, which actually yields to much better results. And I think the patients themselves can then kind of tailor things to whatever their liking is. And I think it's huge. I mean, lasers has played a huge role for patients with rosacea. For hair loss, you have everything from the topicals to the orals to PRP. Now there's research being done on exosomes as well. And so there's a lot of opportunity, I think, here for patients that they have to realize that, it's not that they're stuck with that condition. I think sometimes people come in and they feel defeated. Like, for example, acne scarring. There are ways to treat, such as through microneedling, through lasers, through RF technology, and so forth, that can really help to improve the acne scars enough that they're not as self-conscious. Even if you improve the acne scars by 50 or 60%, not entirely, they don't have the shadow effect of the scars, and the patients feel a lot more self-confident. So there's a lot of things that we can do now that didn't exist even 5 or 10 years ago.
Yeah, I think like Vineet said, a lot of it comes back to quality of life. So things like severe acne and hair loss, uh, even when mild, can give significant quality of life issues. And like a lot of things in skin, the earlier you treat it and the more kind of rigorous you are about the treatment, the better the results are, and you can stave off scarring and other long-term issues.
And we also work very closely with our partners, such as in rheumatology, if someone has, let's say, psoriasis and has psoriatic arthritis as well, or our colleagues in immunology, for example, most of these medications that we prescribe for eczema, they're kind of developed by immunologists, really. We work very closely with pediatricians, kids who come in for molluscum, warts, whatever it may be, vascular lesions as well. oncologists, people come in with skin cancer that may be metastatic or perhaps maybe more advanced. And so there's a big crossover in dermatology because it is the largest organ of the body. People may have oral issues like oral lichen planus, where we have to work with other doctors as well. And so it's actually an interesting crosstalk in dermatology because we do span such a wide field and we cover so much of the body as well.
So yes, looks like in this one in this sub-session, we've covered a lot of ground all the way from acne to immunological disorders to cancer. A little bit confusing for a public audience that may be medically kind of naive. I'll try and take it back one step if I can.
Sure.
Uh, so we started off with a question about acne. So what I understand from what you folks just said is that there is acne, but many different conditions lead to acne, and depending on what that is, the treatment needs to be tailored to the underlying issue rather than everybody getting the same treatment. And that more recently, with the advent of laser therapy and before that isotretinoin, that there are pretty much more or less guaranteed treatment for a condition that affects so many people. Does that about summarize it?
Yeah, I think it does.
Yeah.
I think it really comes down to the patient and evaluating their skin, seeing what areas are involved, because there isn't just facial acne, right? Like people will get acne of their chest and back, and the chest and back skin doesn't heal as well, so that area is more prone to scarring. So I feel like with a lot of patients, my recommendation, and one of those misconceptions that we hear is, well, I'm just going to wait until like this gets further along before I go see a doctor. I don't want to, there's no use in treating it too early. But with most skin things, the earlier you treat it, the better. I think most things in our body, obviously, the earlier you treat something, the better. No one will wait until the bleed in their brain gets bad enough to go to the hospital, right? You want to treat it the moment you start seeing any signs or symptoms. It's the same with the skin. And so if you have a teenager coming in, you know it's 99.9% likely to be related to increase in hormones, puberty related. So you want to use things that are going to really cut down the oil production in their skin. Isotretinoin or topical therapies that cut down on the oil, and laser therapy is one of those options. Versus someone who's in their 40s or 50s, you're using more anti-hormonal agents. There's a drug called spironolactone, which is an anti-androgen that we use on women in that age group. And I feel like that can be really good at kind of slowing the ability of their hormones to affect their skin. Because it's not as much oil as it is the effect of the hormone on that particular skin type. So the type of acne, the location of the acne, and the age of the patient, I think, has a lot to do with what treatments we will choose.
And just to tie
Excellent.
that in, when you have a patient who comes in, let's say a 30-year-old woman or 25, and let's say that she has, issues such as facial hair, perhaps she's maybe a little bit obese, maybe pre-diabetic, you start to think of PCOS and other conditions that may lead to this. So that's when we
Exactly.
work with a gynecologist, so they can do an ultrasound scan of the ovaries. And we try to then formulate a game plan that can help that patient. So, for example, as Dr. Friedman said, with spironolactone, for example, may be an effective treatment option because the key thing is that you got to identify the root cause and then treat it accordingly. And there was a question that came in the chat box about acne and pregnancy. And there's different medications that can be used for women who are pregnant. Obviously, most things are off label and cannot be used and contraindicated, but there are things like azelaic acid that is safe and effective. Some people say that clindamycin topically may be reasonable. You can still do things like extractions and mild facials and things like that. and maybe even like red light therapy that can be used to decrease the acne, but it depends on the type of acne as well. Is it more inflammatory, which is red bumps, or is it more comedonal, which is more of the blackheads and whiteheads? So even within acne, we can, well, we can spend 6 hours on this topic, and go through and dissect this thing so deeply. But yes, there are ways to treat this. And I think getting the appropriate workup is important. Like with hair loss, is it because of thyroid issues? If so, we to refer to an endocrinologist so they can manage that. Is it low vitamin D or is it low iron? If so, then we need to supplement accordingly. Is it genetic? Is there something else that's going on that's inflammatory on the scalp, like dandruff or seborrheic dermatitis? There's other inflammatory scalp conditions that can lead to focal hair loss that is more immunology, like alopecia areata. So knowing the root cause of what is going on is key, because if you don't know the root cause, then you may just spin your wheels and not get what you want to.
So it used to be that when lasers first came out, they said that darker skin tones couldn't use it because of the heat absorption. But has that changed now with the different types of lasers, or is that still an issue with darker skin tones and laser therapy?
It's still an issue. For some reason, people of Southeast Asian descent, regardless of how light or dark their skin is to begin with, are at higher risk from pigmentation from lasers. We don't really understand why that is. Uh, it is what it is. And so when we're treating people from a Southeast Asian area, then we will maybe be more cautious with the settings that we use. We'll use lower energy levels or lower density and say, okay, let's shoot for more treatments, but I feel we can still get an equivalent result. We're just getting there slower. And so we use a lot of fractional lasers or fractional types of devices in those patients. Maybe a fractional laser, like a laser that I use commonly is called Fraxel, but there's other devices out there as well. Maybe among the most common devices in Southeast Asia is RF microneedling, because it combines the benefit of microneedling with an energy source. But by bypassing the skin with the needles and then firing the energy, you don't heat that top layer of skin, so your risk of pigmentation is much less. That's typically the most common issue that I've seen in people of Southeast Asia, also maybe African American patients or South American, Central American patients, is pigmentation issues, primarily hyperpigmentation, which means an increase in pigment.
Do these treatments get very expensive, or are they relatively affordable?
It varies. It varies a lot. Number one, based on the where you're getting treatment. Here in the United States, Beverly Hills versus Topeka, Kansas, it's going to be a very different cost for a patient. So where you are does matter. What kind of device you're getting treated with will matter a lot. How many sessions you need. I'll give you an example. When we're treating scars, I don't give people a number as to how many treatments they need, because scars are unpredictable. It may never be normal skin, no matter how many treatments they do. But what I tell them, and what we know for sure, is that each time you treat it, it will get better and better. So I leave it somewhat open-ended, and I tell people, let's do one, give it a month, see what you think. If you're happy, let's do more. If you're not happy, come back in and we will discuss. We'll get some photos and see, if it's worth changing the plan or if it's worth doing another one and kind of dipping our foot in the pool one more time. So the costs can be very variable. It's hard to come up with one general answer to that.
So we're kind of nearing the last stage of the program, but I wanted to see if we could give an overview on the scary stuff like skin cancers, which I think are fairly common. Uh, could we do an overview on the more common types of skin cancers in general in terms of what causes them, how to look out for them, and a high view on what the current treatments are.
Sure, I'll be happy to kind of answer those questions. So in India versus the US, the types of skin cancers and the incidence and the prevalence are very different. Having said that, in the US, the most common type is a basal cell carcinoma, from which there's various subtypes. In the US, we see around 5 to 6 million cases per year of skin cancer. Number one is basal, second is squamous cell. However, in terms of mortality, the melanoma category is the highest. You have different subtypes within that as well. The South Asian population, because of the fact that the lifestyle is a little bit different, people are not trying to get tan. People are not, out in the sun without trying to wear something like a hat or something, allows them to have a lower incidence of it. But there are certain subtypes that can be more common. If you see a spot, in speaking broadly, on your body that is new, that perhaps is changing size, shape, or color, then it might be worth to take a look at. The majority of them tend to be benign, like a seborrheic keratosis or something like that. But if you see a spot that is bleeding uh, or is changing rapidly, then that may indicate it's active. Now, if there's certain types of cancers that are more genetically induced versus sun-induced, from the sun you get point mutations in the DNA that over time become uncontrolled and therefore cancer with their growth. Whereas if it's genetics, it's kind of a different um, kind of pathway entirely. Um, but in the US, at least, the most common is the basal cell carcinoma, from which you have your various subtypes from nodular, superficial, infiltrative, and so forth, and pigmented. And then you have your squamous cells, and then other types as well. There's some types of skin cancers like angiosarcoma, which are found in all population groups that are actually very deadly, mostly found in sun-exposed sites of the head and neck. And the treatment options for cancer normally, if it's something that's not advanced, is to excise and get clear margins. If there is spread, for example, squamous cell carcinomas have a high risk of spread than basal cell carcinomas because they tend to travel via perivascular and perineural routes. Then we loop in our oncology friends, hem-onc, rad-onc, surg-onc, and so forth. And through a tumor board or whatnot, we'll create a game plan for that kind of patient, be it with radiation, immunotherapy, which is really advanced a lot, chemotherapy, and surgery as well.
Yeah, so there's a lot of options now for cancers, especially like melanoma, basal cells, squamous cell skin cancers that we didn't have 15, 20 years ago. The only options that we had was cutting it out and doing maybe chemotherapy. Now there's drugs, these immunotherapies, as Vineet mentioned, which are actually targeted for specific molecules that these cancer cells express. So they look at the cancer cells, they see what's on there that's not in your other tissues, and so they target drugs specifically to those. And so the drug will bind to those, and then it allows the immune system to kill off those cells more effectively. So it's ramping up your immune system against the abnormal cells, and that can dramatically improve outcomes in patients. And so those kind of drugs would be used with the teamwork between dermatologists and oncologists. And it really takes a team approach to make sure those patients are taken care of.
So, if I can summarize what you gentlemen said, is that if somebody notices a lesion that they didn't have before, or a change in a lesion that they did have before, the thing to do is to, as soon as possible, get it checked by an expert such as yourselves, and then with current latest management, there are many avenues available to diagnose and successfully treat many of these conditions that until recently were perhaps not as well treatable as they are currently.
Exactly right. Yeah. And what I tell people, and this isn't set in stone, but I tell people is take a photo of it, take a photo of it a month later. If you've noticed significant change or you suspect there may have been some change, go to the dermatologist, show them the photos. It will help them evaluate how that lesion has progressed over time. Things that are benign typically will change very slowly. We're talking about over years. They can still change. We all have things on our body that change over time, but a melanoma will change month to month, typically, not set in stone, but often does have change on a month to month scale. And so now that we all have cell phones in our pocket, we have an instant camera system. We can log all of that, and it's very useful for someone who you're going to see if they can see the progression over time.
And so, if we just hit now on a couple of different things, sort of like a quick question answer would be what are your thoughts on Botox injections? It's ubiquitous now. I heard of people having Botox parties, people injecting each other with Botox, but could you give us a little thing on Botox?
Did Vineet tell you about our party last weekend? No, I'm just
That's
yeah, I
right.
mean, Botox is to me like the revolution for cosmetic dermatology. Before Botox, dermatologists did primarily medical dermatology. Very few people ventured into cosmetics. Once Botox came out, the entire field changed. It now has revolutionized, lasers have skyrocketed. Everything is a byproduct of that craze caused by Botox. So it's an extremely useful drug, maybe one of the safest drugs in the world. Uh, the most dangerous poison turned into maybe the safest drug, which is a novel aspect unto itself. So we use it for a lot of things. We use it for wrinkles on the face. We use it for kind of reducing tension in the trap muscle or the calf muscles. We use it to improve migraines. In the US, it's FDA approved for migraines. There's numerous, countless studies now showing that it helps with mood disorders like depression. There's studies going on now, having spoken to psychiatrists on the use of Botox for PTSD, for bipolar disorders, for different personality disorders. So there's a lot of quality of life and psychological issues that could be improved by improving your wrinkles and reducing the tension in your head and face. Because this is what we see. This is what we see in the mirror, and that can help change our personality and our mood over time. So it's an extremely versatile drug. And one thing I didn't mention, I'm sure Vineet would have caught this, is for sweating. We use a lot of botulinum toxin for what we call hyperhidrosis, an increase in sweating. And so we use it for underarms, we use it for hands, people who can't function, they can't shake hands because their hand it just sweats constantly. You can completely shut off that sweating process with one session of botulinum toxin injections. So it's pretty remarkable what this drug can do. And,
There's
and
a
one
patient.
other thing, so sorry, Vinny. One other thing I wanted
Yeah.
to say before I forget is we say Botox, but Botox is a brand name, right? It's like Coke or like jacuzzi or like a jet ski nowadays. People call the apparatus by that name, but that is a brand name. Those are brand names. Botulinum toxin is the name of the actual molecule, and there's many different manufacturers that make it. Botox was just the first one to come to market. Please, Vineet, sorry.
No, 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 all good. I mean, and just to add to your indication list, there's a patient who came and saw me, 35-year-old woman, has 3 kids, has a lot of grinding of her teeth, and we did her
Yes.
masseter injection, and her tension headaches and so forth resolved. And so there's a big improvement that can be done once again from the quality of life scale along with the cosmetic scale as well. And one has to keep in mind that Botox in the US is regulated highly in terms of, there's 4 or 5 different types of the botulinum toxin that's approved in the US. But one has to be careful of knowing who's injecting what, because there is shipments of fake Botox out there in the market that the US has actually in certain states issued an FDA advisory because people have gotten sick because they went to certain places where they probably weren't using the appropriate product. And there's a lot of counterfeit out there. And so once again, one has to kind of be mindful and know who they're going to and make sure they're going to a place where people know how to inject, who know the anatomy, um, and, uh, and are confident in the quality of the product that's being injected as well.
Yeah,
So just yeah.
yeah, no, harping on that, the drug that we're injecting, the amount of drug in a vial is in the billionths of a gram, right? The amount of toxin in there. So you can imagine if someone is using kind of industrial grade botulinum toxin, for lack of a better term, and you're not using a product made by a reliable company, you don't know what you're getting. And in a small change in that billionth of a gram could be catastrophic. So you want to make sure that the product you're getting is legitimate. You're going to a certified dermatologist, someone who is well trained and will be injecting you with the right product.
Excellent. Wow, I didn't realize that one word would open up such a large, large number of options for utilization. That was amazing.
Yeah.
The other thing that I think we can quickly touch on is I think that one of the most distressing things we find is hair loss in women. I think that is uh, understandably very, very distressing. And could you do like a 2-minute session on hair loss in women and
Yeah, so when you see a woman with hair loss, the majority of the time, it's common things being common. It's most likely going to be what we call androgenetic alopecia. Androgenetic means that it's genetically motivated and due to the effect of androgens or hormones in our blood that affect the growth of the hair. So as women get older, the hair loss as their estrogen goes down and the effect of testosterone goes up in kind of that seesaw fashion, it causes hair loss like we see in men earlier, because we have more testosterone, less estrogen, so we have that problem earlier on in life. So it can be really, really damaging psychologically. Obviously, the quality of life issues. The first thing that, as a dermatologist, you want to rule out is this something other than androgenetic hair loss? Could this be an inflammatory hair loss? And the inflammatory hair losses can be scarring or non-scarring. And so if you have a hair loss that scars, you need to treat it as quickly as possible. You need to stop that inflammatory process. You need to put them on. There's many different forms of medication that can be used for those, but those conditions are probably irreversible. So every day that you wait on treating that hair loss could be more permanent problems down the line. But things like androgenic alopecia, the hormonally driven hair loss, we have a lot of treatments for it these days. Like Vineet said before, we have topicals like topical minoxidil. The common name in the US is Rogaine for that. We have oral medications. And now, I'm part of one of these studies. They're going to be releasing in the next few years a sustained release minoxidil pill. The problem with minoxidil that we have right now as a pill, it's that immediate release, and you get kind of this peak over an hour, and then 23 hours with no effect. So this is kind of releasing that drug over 16 to 20 hours, and should promote dramatically better results. So the most important thing when you're addressing hair loss is the earlier you start to treat it, the better the results are going to be. Because once that hair gets smaller and smaller and smaller, and that's why it looks like your hairs are disappearing, it's actually shrinking inside your skin. the earlier you treat it, the more of those cells, the more of those hair follicles that you can recover. And so waiting is never the right option. When someone just starts to see hair in the shower, that is the time that they need to start treating it, because you can completely prevent the progression of that hair loss. Versus if they have a bald scalp, there's no coming back from that. At least we don't know how to do that to this day and time.
So it's way, way too late for somebody like me then.
Well, hopefully we come up with, and we don't know, we may come up with an advancement 5 years from now that completely revolutionizes how we understand hair loss treatment. There is a thought that those miniaturized hairs may be reversible. We just don't know how to do it. But that doesn't mean it can't be done. It just means our technology hasn't reached that stage yet.
Excellent. Hey guys, thank you so much. I think it's been just a amazingly educational and instructive session.
Great.
Thank you very much. And for the audience, I once again like to remind you that all the information was general and is meant to just give you a little flavor of what all is available in the region of dermatology. Please talk to your doctors. And if you want to, it's very easy, make an appointment with Dr. Friedmann or Dr. Mishra through myamericandoctor.com. And good luck to you all. Thank you very much for listening.
All right.
Thank
Thanks
you.
for having us.
Thank you. Bye-bye.
Thank you.
All right. Bye-bye.
Bye-bye. Technical people, are we done? What do we do? Just hang up? Hello?
Yeah, I think we're probably done now. Yeah.
Okay. Well, thanks, guys.
Yeah.
All right.
See
Yeah,
ya.
that was good. Yeah, thank you so much.
Yes,
We covered a
doctor.
lot.
Yes,
So,
doctor. Thank you so much. Yeah, it's
everything
done.
good? Everything recorded all right?
Yeah, recorded, and we got some questions also.
Yeah, we tried to cover them as they came along. Hopefully, we got them done.
Yeah,
Yeah.
sure.
Thank you. Thanks, guys.
All right. Have a
Thank you.
Thank you,
wonderful
doctor.
weekend.
See
Thank
you.
you.
Bye.